Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which you may find useful in your line of duty. So welcome to part 55 of our pharmacotherapy MCQ series. Question number 1 reads, Mr. J.M, a middle-aged male patient with a past medical history of erectile dysfunction, presents to your urology clinic for a follow-up appointment. He has failed multiple phosphodiesterase type 5 inhibitor therapies. He wasn't happy or satisfied with vacuum erection device, and during today's appointment he agrees to start intraurethral Alprostadil therapy. So my question to you is, which of the statements below regarding intraurethral Alprostadil therapy should form part of the medication use counseling your urologist would offer him prior to initiation of this mode of therapy? Could it be that a maximum of 2 doses should be used per week, or would it be that a condom should be used with this therapy if the sexual partner is expectant, or is it that the medication should be stored at room temperature, or is it that this medication should be administered 2 hours prior to a desired erection? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Condom should be used with this therapy if the sexual partner is expectant or pregnant. I would just like to emphasize that Alprostadil, like misoprostol, is a synthetic prostaglandin E1 analog, which is contraindicated for use if the sexual partner is pregnant unless a condom is used. I would like to remind you that misoprostol has been used for labor induction and for cervical ripening or thinning, but it can also induce an abortion and have adverse effects on the uterus, so use it cautiously if you need to. Now, since Alprostadil is inserted into the urethra, expelling the drug into the vagina of a pregnant sexual partner may lead to unwanted effects or complications, and this may occur during an ejaculation. And I would just like to add that on the product insert of this particular product, there is a statement that there is no information on the effects on early pregnancy of prostaglandin E1 at the levels received by female partners. Now, Alprostadil intraurethral shouldn't be used if the female partner is pregnant unless her partner uses a condom barrier. That is a quotation from the literature insert. Now, I would like to also add that intraurethral alprostadil can be administered to a maximum of 2 doses per 24-hour period, not per week as in alternative A, and that makes answer A wrong. And it should be administered 5 to 10 minutes prior to a desired erection and not 2 hours, so that makes answer D wrong. And it's also specified that the medication should be stored in a fridge, which makes answer C wrong. So let's move to the next question, please. Our next question reads, Mr. J.A.K, a middle-aged male patient who suffers from BPH, benign prostatic hyperplasia, requests his urologist to switch him to a medication he read about in a medical journal, which he claims can prevent progression of symptoms from worsening over time. My question to you is, which of the medications listed below would best meet this gentleman J.A.K's expectations? Would it be Tolterodine? Would it be tamsulosin, finasteride, or phenylephrine? I'll give you 10 seconds to choose the correct answer. Finasteride it would be. Now, alpha blockers are symptomatic treatments for BPH. I would like to add that the 5 alpha-reductase inhibitors actually reduce the size of the prostate in patients with substantially enlarged prostates. And this effect has been shown to reduce the progression of symptoms and decreases the patient's risks of acute urinary retention and prostate surgery. So that explanation makes finasteride the best choice in this particular question. Let's move to the next question, please. It reads, Mr. ALJ, a 52-year-old male patient, presents to your urology clinic with a past medical history of erectile dysfunction, coronary artery disease, hypertension, and dyslipidemia. The urologist determines that Mr. ALJ isn't a candidate for a phosphodiesterase type 5 inhibitor due to drug-drug interaction potential. He is still desiring something for his erectile dysfunction and seeks to know if Cavaject, Alprostadil to be specific, is an option for him. So my question to you is, which of the following would be a contraindication to the use of this form of Alprostadil for any patient? Could it be urethral stricture, sickle cell trait or disease? Would it be G6DP deficiency and a history of hemolysis, or sexual intercourse with a pregnant woman using a condom? I'll give you 10 seconds to choose the correct answer. So sickle cell trait or disease would be the correct answer. I would like to remind you that Alprostadil or Cavaject is a prostaglandin vasodilator used in the treatment of erectile dysfunction, but not in men with predisposing conditions that increase the risk of priapism, which may include, for example, sickle cell disease or trait, multiple myeloma, leukemia, or anatomical deformities of the penis or penile implants. Now, I would like to emphasize that sexual intercourse with a pregnant woman should be avoided unless the male is wearing a condom after the use of Alprostadil. And then just remember that Alprostadil or Cavaject is a prostaglandin vasodilator used for the treatment of erectile dysfunction in patients who aren't candidates for phosphodiesterase type 5 inhibitors. Now, Cavaject is the dosage formulation used for intracavernosal intracavernosal injection at the dorsolateral aspect of the proximal 1/3 of the penis. Now, the initial dose is determined by the prescriber in the clinic and shouldn't be adjusted by the patient. And I would like to add that prostaglandins can cause uterine contraction if exposure occurs, so be very cautious when a male who has received them comes into contact through sexual intercourse with a pregnant or an expectant lady. Just as a by the way, let's move to the next slide, please. The next question reads, Mr. J.F.A, a 55-year-old male with erectile dysfunction, is about to be initiated on Alprostadil Intracavernosal Injection therapy due to a contraindication to Sildenafil and other similar products. That's the PDE type 5 inhibitors. So my question to you is, which of the statements below is true about Alprostadil? Is it true that Alprostadil is metabolized by the CYP3A isoenzyme system? Or is it true that treatment efficacy with Alprostadil Intracavernosal Injection therapy is as good or better than Sildenafil? Or is it true that Alprostadil is limited to patients with an organic erectile dysfunction etiology? Or is it true that the dose of Alprostadil must be decreased in patients with renal insufficiency? I'll give you 10 seconds to choose the correct answer. So it is true that treatment efficacy with Alprostadil Intracavernosal Injection therapy is as good as or better than Sildenafil. Now, we know that Alprostadil is an alternative to patients unable to take or to tolerate Sildenafil or any other phosphodiesterase type 5 inhibitors. Now, the intracavernosal injection dosage form has reported efficacy similar to or better than Sildenafil. That is, the comparison is 70 to 90% in favor of intracavernosal Alprostadil versus 56 to 82% for Sildenafil. That is quoted in clinical studies that have been conducted. Now, additional advantages of Alprostadil include its lack of significant drug interactions and the fact that no dosage adjustments are necessary for renal or hepatic insufficiency. And that makes answer D wrong. And I would also just like to add that Alprostadil can be used for patients with multiple erectile dysfunction etiologies, including neurogenic, psychogenic, or organic etiologies. And the major drawback to its use is its unfavorable route of administration and the resulting unnatural erection. Just as a by the way, let's move to the next question, please. And it reads, a male patient suffering from BPH, benign prostatic hyperplasia, seeks clarification during today's appointment at your urology clinic concerning his condition. My question to you is, which of the following is created by the poor correlation between symptoms and prostate size? Is it importance of pelvic floor muscle exercise? Is it appropriateness of watchful waiting for many patients? Is it appropriateness of finasteride for all patients? Or is it importance of early pharmacologic intervention? I'll give you 10 seconds to choose the correct answer. So the correct answer is appropriateness of watchful waiting for many patients. Now we know that watchful waiting is an accepted and appropriate treatment strategy in many patients with benign prostatic hyperplasia, with unbothersome symptoms specifically. And this is because there is generally a poor correlation between prostate size and symptoms, and creating a situation in which patient's preference is a key part of the treatment decision is the end result. Let's move to the next slide, please. The next question reads, Mr. DJT, a middle-aged male, presents to your urology clinic with hyperprolactinemia and decreased libido. So my question to you is, by which of the mechanisms listed below can elevated prolactin concentrations lead to a decline in male libido? Is it prolactin directly inhibits the production of testosterone in the testes? Is it prolactin stimulates the release of FSH and LH from the anterior pituitary, leading to a decrease in testosterone production in the testes? Or is it prolactin stimulates the release of both FSH and LH, leading to a decrease in testosterone production in the testes? Or is it true that prolactin increases sex hormone binding globulin, by which in turn binds to testosterone, decreasing circulating concentrations of the same? I'll give you 10 seconds to choose the correct answer. So C is the correct answer, and I'll tell you why. Now, hypothalamic gonadotropin releasing hormone, abbreviated as GnRH, stimulates the release of both FSH and LH from the anterior pituitary in a pulsatile manner. Now, in men, the FSH is responsible for regulating spermatogenesis in the testes, while LH is responsible for regulating testosterone production from what we call the Leydig cells of the testis. Now, prolactin inhibits the release of FSH and LH from the anterior pituitary, thus inhibiting the above processes, which leads to lower testosterone levels and decreased spermatogenesis. Now, symptoms of low testosterone levels include decreased libido, reduced fertility, and decreased muscle mass with weakness, just for your information. Let's move to the next slide, please. And the question reads, your urologist is considering medical management or pharmacologic management of erectile dysfunction in a male hypertensive patient who takes organic nitrates as part of his antihypertensive regimen. So my question to you is, which of the medications listed below would be contraindicated in this patient's case? Would it be alprostadil, tadalafil, bromocriptine, or testosterone? I'll give you 10 seconds to choose the correct answer. So the tadalafil is the correct answer. Now, tadalafil, which is marketed as Cialis, and other phosphodiesterase type 5 inhibitors like Sildenafil, Viagra, or Vardenafil, Levitra, are contraindicated to be used concurrently with organic nitrates, since there is an increased risk for hypotension. Now, both phosphodiesterase type 5 inhibitors and organic nitrates increase the levels of nitric oxide, which in turn leads to smooth muscle relaxation, causing hypotensive effects. And that is why the two should not be co-administered under any circumstances unless inevitable. Let's move to the next slide, please. And the question reads, Mr. ALW, a 60-year-old male patient, presents to your urology clinic with a past medical history of hypertension. He has a bundle branch block, and he experiences orthostasis. The urologist prescribes a medication for the treatment of benign prostatic hyperplasia. Now, paying attention to safety, my question to you is, which of the medications listed below should be avoided in the case of Mr. ALW's pharmacologic management or treatment? Should it be Tolterodine, prazosin, tamsulosin, or finasteride? I'll give you 10 seconds to choose the correct answer. So prazosin it is. Now, just like to emphasize that when considering the use of alpha blockers in patients with BPH, prazosin, which is marketed as Minipress, isn't considered first line because of its greater likelihood to produce orthostasis. Now, this is likely due to relatively non-specific alpha receptor properties, so avoid using it in this cohort of patients. Let's move to the next slide, and the question reads, which of the statements below is the most accurate about Ditropan? Is it true that its generic name is Tolterodine? Is it true that it has antimuscarinic properties? Is it true that it can cause blurry vision and urinary retention? Or is it true that it can inhibit 5-alpha-reductase? I'll give you 10 seconds to choose the correct answer. So both answers B and C are correct. It has antimuscarinic properties and it can cause blurry vision and urinary retention. Now, Ditropan is also known as oxybutynin. That is its generic name, and it is an antispasmodic agent that works by inhibiting the effects of acetylcholine on smooth muscles, but it doesn't do so on skeletal muscles. It is used in the treatment of overactive bladder. It has antimuscarinic or anticholinergic activity, which can lead to the blurry vision, constipation, and urinary retention. Now, Tolterodine, which is marketed as Urethral, is an anticholinergic agent used in the treatment of overreactive bladder. Now, dutasteride, marketed as Avodat, and finasteride, marketed as Proscar, are both 5-alpha-reductase inhibitors used in the treatment of benign prostatic hyperplasia. So all those make answers B and C the correct answers to this question. Let's move to the next question. And it reads, Mr. J.A.K, a 55-year-old male, is filling a prescription for Tolterodine at your hospital pharmacy and seeks to know what to expect in terms of the most common side effects. So my question to you is, which of the following statements is true with regard to these side effects? Is it headache, abdominal cramping, vomiting, and increased heart rate? Is it dry mouth, headache, dizziness, and dyspepsia? Is it dyspepsia, sexual dysfunction, nausea, and sedation? Or is it headache, diarrhea, insomnia, and nasal congestion? I'll give you 10 seconds to choose the correct answer. So dry mouth, headache, dizziness, and dyspepsia is the correct option. Now, Tolterodine is an antimuscarinic agent commonly prescribed for what we call urge incontinence. Its most common side effects are related to its antimuscarinic actions on the body. Hence, it causes dry mouth, headache, dizziness, and dyspepsia. Let's move to the next slide, please. Our next question reads, Mr. W.O.C., a 45-year-old male patient with newly diagnosed erectile dysfunction, seeks to fill a prescription for sildenafil at your hospital pharmacy. My question to you is, which of the following counseling points would you expect your clinical pharmacist to include when educating Mr. W.O.C. on the use of sildenafil? Would it be organic nitrates can be taken concurrently with sildenafil as long as they are separated by at least 6 hours? Or would it be high fat meals delay the absorption of sildenafil? Or would it be sildenafil should be taken once a day, every day, to improve overall efficacy? Or would it be no dose adjustments are necessary in severe renal or hepatic insufficiency? I'll give you 10 seconds to choose the correct answer. So the correct answer would be high fat meals delay the absorption of sildenafil. Now, when sildenafil is taken with high fat meals, its absorption time is delayed, as is the resulting peak plasma concentration, and this may alter its overall efficacy. Now, tadalafil and not sildenafil has a daily formulation which is marketed as providing erectile dysfunction assistance for spontaneous moments at any time of the day without planning ahead, like the PRN or the on-demand formulations. Now, any formulation of organic nitrates is officially contraindicated to be used concurrently with type 5 phosphodiesterase inhibitors, including sildenafil. And that makes answer A wrong. Now, from the pharmacokinetic standpoint, the half-life of sildenafil is approximately 4 hours. So, if medically necessary, use of an organic nitrate following sildenafil should be separated by at least 24 hours and not 6 hours, like in the case of alternative A. I would also like to add that sildenafil dose should be adjusted in both hepatic and renal insufficiency as per the prescribing recommendations that are available out there in literature. And that makes answer D wrong. So all those points make our alternative B the correct answer. Let's move to the next slide, please. And the next question reads, which of the medications listed below is used in the medical management of overactive bladder? Is it dexlansoprazole? Is it Tolterodine? Is it olanzapine? Or is it lisdexamfetamine? I'll give you 10 seconds to choose the correct answer. So Tolterodine it is. Now, Tolterodine, marketed as Ditropan, is an anticholinergic agent used in the management of incontinence or overactive bladder. And lisdexamfetamine, which is marketed as Vyvanse, is a stimulant medication used for the treatment of ADHD. Then dexlansoprazole, which is marketed as Dexilant, is a proton pump inhibitor for the treatment of GERD. And olanzapine, marketed as Zyprexa, is an atypical or a second generation antipsychotic. And answers A, C, and D have nothing to do with this condition, and that makes Tolterodine the correct answer to this question. So, my highly esteemed viewers and listeners, that brings us to the end of part 55 of our pharmacotherapy MCQ series. If this video benefited you in any way, please remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. I thank you very much for viewing it and for listening to me. And I sincerely appreciate your partnership and your continued support and kind collaboration. I look forward to interacting with you in part 56 of our pharmacotherapy MCQ series. Thank you for always being there for me.